Jagan.
Education is the most powerful weapon which you can use to change the world. Nelson Mandela. Good afternoon, everyone. Today, I welcome you to the 8th webinar conducted by the Alumni Association of Government College of Physiotherapy. Today's speaker, Lalitha Sridhar, is a rehabilitation consultant, development therapist, and an educator specialized in sensory integration and neurodevelopmental therapy. She belongs to the 1985 batch and holds a master's degree in psychology. She is an educator and counselor for children with special needs and their parents. She has over 30 years of experience in the field of rehabilitation of children with special needs in India and abroad as well. She has worked with children across all age groups. Her core area of work involves assessment of children right from infancy for developmental delays, disabilities, early identification and interventions, inclusion in normal environment, formulating special school program in line with development, in identifying children for pre-vocational and vocational training and setting up of resource room in normal school. She has also worked with parents in guiding, training and empowering them in their journey. She has presented several papers in conferences in India and abroad. Furthermore, she conducts training program for normal school teachers and resource persons working in the area of special needs. Something to be noted is her uh, early intervention program that has received an award from Unilever for the impact on early childhood development. She was also conferred by FICCI recognizing her work in early interventions in rural areas. Now over to you, ma'am, for the session.
Thank you, Jagan, for those kind words. Good evening, everyone. It's indeed a pleasure and honor to be present here today and be a part of this group and connect with my alma mater after a long, long time. I am Mrs.Lalitha Sridhar, an alumni of 1985 batch, and I'm here today to speak about the role of therapy in children with special needs. Two roads diverged in the wood, and I took the one less traveled by, and that has made all the difference. You must be wondering, what are these lines doing here? These are quotes taken from a poem. The road less traveled by is the area of special needs, which I mean. And I have been in this field for 30 years because most of us therapists work in the field of orthopedics, neurology, respiratory therapy, cardio rehabilitation, or sports medicine. And pediatrics and special needs, as I've seen in this journey, is a road which is less traveled by. And I'm here today to share my learning and experiences in this field towards the contribution the therapist can do towards improving the development of children. I call this the road not explored enough. Yes, still, I always wonder why this space or this field, there are not many therapists who are taking up to as a practice and to develop their journey after their education. In my mind, the following reasons comes true because there's not a lot of awareness of this field first amongst the rehabilitation field, amongst the therapists and other resource people working in this area. Next, I feel it is a very, very long process working with children and it takes a lot of time and effort. Next, it requires a lot of patience and a lot of work with respect to special needs and children with special needs with NGOs. So it becomes more of a social cause and the remuneration is not very high. And still, we don't have the best practices which are being implemented in this area of special needs. So I just feel that these are the few hitches which has hindered people from or prevented people from exploring this area to take it as a profession. But after working for so many years with a lot of understanding and conviction, I can really say the contribution of the therapist and the therapy in this field is immense. So what do we as therapists and what as therapy we do? What do we do in other areas as therapists? Whether it is orthopedics, neurology, or other areas, we alleviate pain, we improve the range of motion, we strengthen the muscles, thereby we improve the quality of life. So what? So what happens in the special needs rehabilitation field? We as therapists, provide therapy, here I would really like to emphasize two important areas of neurodevelopmental therapy and another area of sensory integration, which is really, really specialized to help the child to develop. So, what does development here? We address to develop the child holistically, and wherever there is a lack, to improve the lack and facilitate or help the child to accelerate the development. So it's an immense contribution that we do because we bring about the holistic development of the child, and it is the child who develops and becomes an individual. So we can say, now let us say we have spoken about development. So generally, what do we speak? What is it that we understand by development? We can say anything in these three: a process by which a child changes over time, like from the time he is born, then he gets up to walk, and then again his school going age, then he becomes an adult, and over his lifetime. Then we can also say it is the time period from the time of formation and to become a fully functioning adult. That is also called as development. These are all the common definitions, or commonly what we call as development. Another definition to development is it is the journey of an individual. That is how we move from being fully dependent on our caregivers and parents from the time we are born to become fully independent. Of course, as we approach our old age based on our own health conditions, we again go back into partially or fully dependent system. But the development from a child being dependent on the caregiver and the parents to become a fully independent person, it also comes under the general category of development. So now we have classified, or we have explained what generally development is about. What are the things which contributes to these changes, or these journey from dependence to fully independence? Let's see that. So we categorize this against 6 developmental domains. So what are they? The first one becomes the neuromuscular, the most important one, which consists of both the gross motor development and the fine motor development. I leave the sensory development to the last. Next comes the cognitive development. It is to do with understanding, thinking, and involving all the process related to the brain, understanding, thought process, which lays the foundation for future academic learning. Next is the speech and the language development, our ability to communicate with one another, our ability to understand each other, which makes a whole lot of difference to an individual development. Next is the social development, our interaction with the environment and the society, and our behaviors relate to the social development. Next is the functional development, which is very, very important, age appropriately able to perform the functional skills. This starts even from the year 1, year 2, goes up to year 7, and all through the life, age appropriately, the functions which we are able to do. And this is the development which helps us to move from dependence to the independent stage. So, why did I leave the sensory development? All the other development, like the neuromuscular, the cognition, the speech and language, and the social development, how does it happen? It is through the sensory development which enhances or helps the other development to happen. You may ask why and how. Our brain receives the information about what is happening around us through our 5 senses, and that information is processed in the brain, and after processing, the response is given as a learning or an adaptive response. So the sensory development of the tactile, the proprioceptive, the vestibular, the visual, auditory, and the gustatory forms a very, very important domain which helps all the other development to take place through their information which they send to the brain, and the brain organizes them and provides them and gives them as a response, as a feedback. And that is how each and every other development takes place, and that forms the foundation. And it is very important that in every individual and in every child, the sensory development is properly developed and matured and consolidated, so that other areas of development doesn't get stagnated, and we are able to see that the child moves up in every area of development. Today in this presentation, I will be moving improving a lot more and concentrating on the sensory integration and the sensory development, because that is the focus which I would like to take through this presentation.
Ma'am, sorry to interrupt, ma'am.
Yeah,
You have to again share the screen because the layout has changed.
the layout has changed.
Yeah, from the recording side, not from your side. So can you redo the same thing, same process again?
I have to escape and then redo it?
Yeah, you have to just go out and again
Yes.
share the screen.
Okay.
Yeah. Extremely sorry, ma'am.
No problem there.
Jagan, can you please help, ma'am?
I'm there, but the
Sir, does she need to turn off present screen and again turn on, or is it okay if ma'am just slide shows again?
you want me to come out completely and then turn it on?
Sir?
Jagan, I think she can go
Jagan,
for a slideshow. It's easy.
No, sir. No, sir. The layout has changed. From the recording side, the layout has changed.
Okay.
Should
Ma'am,
I?
yes, ma'am. You
What
have
should
to
I
go
do?
back, stop presenting, and then again start
Yes.
presenting.
Yes, ma'am. Yes.
We have to stop.
Just
Presenting
minimize
and
the
I-
screen,
yeah.
ma'am. Minimize your slideshow.
Yeah, okay.
Yeah. Now you have to just you can close the other tab, ma'am. You have to stop presenting now. After that,
Wait, where is the stop? Wait. Resume your presentation, it's asking. Can I go
yes,
there?
ma'am. Yes, ma'am. You
Okay.
can do that.
Resume your presentation. Resume presenting.
Yes, ma'am. You're presenting now. You can open that slideshow now.
Yeah.
Slideshow, ma'am. Now. Yes, ma'am. It is starting from the first one. Sir, is
First.
that okay now? Is it visible?
Yeah, it's present. It's okay. It's okay.
Thank you, ma'am.
Thank you, ma'am.
Okay. Sorry for this interruption. Just to recap, we were speaking about the developmental domains and how it is important. The sensory development plays an important role in helping the other areas of the developmental domain to improve. And so we are going to focus in this presentation. I'm going to focus more on the sensory development and the sensory integration, which is responsible, which is really, really helpful in helping a child to develop. So, what are the various conditions we see with relation to special needs? We always define special needs as children who are already at risk of developing a disability condition or they develop later. So, in this, the most common one which we are all aware and a lot of work is happening is cerebral palsy. The three highlighted ones, the autism, the attention deficit hyperactive disorder, which is commonly called ADHD, the learning disability, is what I'm going to take you on this journey. And then, of course, we know syndromes, Down syndromes. There are a lot of centers which work with children with Down syndrome. Then we have the developmental delay, the GDD, the gross developmental delay, and others. So let us look into a small peep into autism. What is it? So autism is an area which is upcoming in India, and a lot of work is happening in this field. It's a pervasive development disorder in children. It is not commonly diagnosed until the age of 3. Though it is possible to diagnose this as early as 1.5, now there are research which says which can be even identified by 3 to 6 months by having the red flag identification, but it's not commonly diagnosed until the age of 3 because that is when the parents really feel the child is not speaking and definitely I need to do somewhere, and they push and bring the child for assessment. The main important characteristics of autism, if you look at it, are there is a lot of issue in cognitive functions, a lot of issues on communication. Social communication is a big issue here. Children will be verbal, but they will not be able to communicate. So here there is a difference between speech and communication, where speak they are able to produce words, but not ask their needs or communicate in way of making others understand themselves, or they are able to understand others. Then the last but not the least is the impairment of social interaction. Because of the communication lack and because of the cognitive challenges, a lot of issues on social interaction and social development takes place. So you may be wondering, where is it as therapists we are going to contribute here? I would definitely like to answer this question after we look at ADHD and the learning difficulty. Next, we are looking at attention deficit hyperactive disorder, which we commonly call as ADHD. This is also another childhood disorder which is diagnosed in school, where the terminology itself explains attention deficiency. So, where the attention span is very less, and even to complete a small activity, they cannot do it. Even a minute of attention is very, very difficult for them to get. And next, hyperactivity, constantly moving and not sitting in one place, and impulsivity. It's a very, very important emotional factor where they don't have emotional control over what they are doing. So they have a lot of aggressive behaviors like throwing, pushing, and sometimes it could be a harmful behavior. So attention deficiency, hyperactivity, and impulsivity are the three key features which is diagnosed only in the time of school. Because even though we see a lot of this when the child is developing at home too, parents generally describe saying that this child is really active. Oh, he is developing so well, and he is able to run around and play more, and so many other things. But if you look at it very subtly, this attention deficiency will cause a lot of learning deficiencies because they will not be able to focus and concentrate. And if you try to look at it, the child will have other areas of difficulty like performing his own functional skills and other motor deficiency, which we'll be talking a little later. Next is learning difficulty or dyslexia. So this is also another childhood disorder which is generally seen in the or identified in the school level. Here what again, there is a difficulty in focus and attention. There is a difficulty in reading, that is reading, writing. What happens in the child enters the school level, a lot of this thing is expected in the academic front on reading and writing, but these are the areas where the child shows deficiency and it becomes a little challenging for the child to continue with the education. And that is when it is discussed. If these cognitive challenges are not addressed, all these children get into the spectrum of disability. But these are all areas which can be addressed, and by proper team approach and the contribution of the therapy and the therapist can make a whole lot of difference in helping them to come out of the developmental lag and have a near normal inclusive education with respect to their age. So I'll come to this later. So we saw the general characteristic of autism, we saw the general characteristics of ADHD, we saw the general characteristics of LD. But because of all that, what is it that these children actually go through? There are a lot of other problems associated with autism, LD, and ADHD, which I put it together. The main important feature they have is the point number 7, which is there on the slide, is the sensory integration dysfunction. That is the sensory development is not adequate, or it is underdeveloped, or it is overdeveloped, thereby causing a lot of disruption in the other areas of development. What are they we spoke about? We spoke about the neuromuscular, the cognitive, the speech, the social, and the functional. So when you actually see autism, because of the sensory integrated dysfunction only, they have a lot of issues in developing their language, in developing their communication, in developing their cognitive skills, that is understanding, thinking, and in developing their functional skills. So it is a very, very important area of development that we understand sensory integration. And in all these three, you do have a sensory integration dysfunction, which could be it is immaturely developed, or it is underdeveloped, or it is overdeveloped, or it is not functioning in an integrated way. So what is integrated way? I'll explain to you a little later. Along with the sensory integrative, because of the sensory integrative dysfunction, what we see is we see children having other features also, like reduced tone of muscles. Tone of muscle is not like, totally low tone, but you will see it is not a normal tone. then primitive reflexes still present as the child moved from the childhood to the mid-school and the adulthood. If the primitive reflexes are still present, it causes a lot of hindering in their day-to-day movement and activity. That causes a lot of delay in learning other skills. Next is the bilateral motor coordination. When you don't have the bilateral motor coordination, all your functional skills becomes very, very difficult. Next, midline crossing activity. Our ability to cross the midline, that is hands crossing opposite direction, our legs crossing in the opposite direction, vertically, horizontally, is very, very important also for other development to happen and for the day-to-day performance of every activity. So when there is a difficulty in midline crossing, what happens is reading, writing, eating, all these skills becomes very challenging for these children. Next, difficulty in body boundary. This is a very, very nice thing when you see children, when you work with children with autism, but you see they actually know, they keep bumping into each other, or they keep going and banging against the table, and they keep banging against everything they see. Why exactly this happened is that restriction of my body ends here, and that is the boundary of another object or another person is not there in these children. So that causes a lot of body boundary issues. Next, perceptual motor difficulties. Because of the perception and the motor, that is movement together, we are able to perform a lot of our movements with precision and ease. There will be a lot of difficulty in this. So if they want to take something, the hand will move in one direction, the other hand will move in direction, and the leg will move in one direction because of the perception, motor difficulty, and because of the lack of bilateral motor coordination also. Then position of body in space. Where am I in this space? Am I sitting? Am I standing? Look at ourselves, even in this presentation, if you are constantly trying to think, am I sitting? Am I stable? Or will I fall down? It causes a lot of focus and inattention, and that causes a lot of difficulty in focusing in what is happening in front of you. If you look at LD and ADHD, one thing which I put up also is they have difficulty in focus and attention. This is also due to this position of body in space, there is a lag in that. So constantly they are fidgeting to make themselves comfortable and secure, because feeling a sense of secure is very important, and it starts from the womb till our last day of life. And here this security is not there, and the child is expected to sit in a classroom or learn something. That is not happening. Then over or under reaction to sensory stimulus. Sometimes these children, even to mild sensory stimulus of light or mild sound, they will react in a very different way, and that causes a lot of behavior issues. Next is the gravitational insecurity. That is, we should feel comfortable in using that fear of falling, and eliminating the gravity and being in positions which is against gravity. That is also, there is a lag in that area for these children. All these things are not because the child has some motor delay, or the child has some muscle strength issues, or the child is having some range of motion delay. It is all due to the sensory integrative dysfunction. So all these things causes this, and in that specifically in the sensory integration dysfunction also, it is mainly the three areas of proprioception, vestibular, and tactile, which is the key senses which is responsible for development of the motor skills, both the gross motor and the fine motor. And because of this, the other areas of development also gets affected. And if we are able to work through the sensory integration and address these issues, we will be helping the child to develop in the other domains, thereby minimizing the symptoms which they are having and help them to develop. So what exactly the aims of therapy? Having said this is all the domains and this is what it is. So what are we going to do? We are going to enhance the gross motor and the fine motor functions of children with special needs. That is, work on both the gross movements and the fine movements. And most importantly, we are going to work on the sensory stimulation or the sensory integration therapy, both to develop and the perceptual motor skills, and to develop the proper position of the body. And the last but not the least is enhancement of independence in activities of daily living skills. This is the very important area, because the activity of daily living, for that you need to have motor skills, you need to have adequate sensory skills, and you need to have the cognitive skills. Even to go to a toilet, and for a child, and passing urine, and having a completion, and then completing the task independently, involves motor, cognition, and the sensory system. So for each and every activity of our daily living, and for each and every learning we undergo from childhood to the adult, and all the experiences we undergo involves the motor skills, the sensory skills, and the cognitive skills. And that is where the therapists play an important role in enhancing and fine-tuning the movements, helping them to overcome their sensory deficiencies, thereby helping them to develop in other areas, and also children with needs become independent in ADL skills. So now we have finished the first bit. Now we actually get into what is sensory integration and what is the sensory integration therapy about. So it is nothing but how the brain receives and processes the information which the senses provide. It's a development process, and it is a part of the human nervous system. Both the brain and the spinal cord are involved in that. So it is the ability that the information is taken, organized in the brain, and respond appropriately, or produce an adaptive response, or do a learning. So very, very important, because this is a basis, because we can use the sensory integration therapy in fine-tuning it in other conditions also. In ortho neuro today, it's an upcoming field where the sensory integration, how sensory feedback can be used for motor development, is another area which has been now really researched, and a lot of development is happening in this field. So how does this happen? This is the next. So we are talking about sensory integration and all those areas. So now let us look at a small purview about what is the sensory system. That you need to have something like, you need to have some organ, some system to do a certain function. So now we are going to see about the sensory system. In the sensory systems, actually I spoke about 5. Here we have classified into exterior receptors, interior receptors, and proprioceptors. So what is it that exterior receptors are? That receptors which gives information about the outside world to inside the body, that is the brain. Am I clear? I will just go through. Exterior receptors are the information about the environment which is given to the body. Otherwise, brain is like one prisoner is in the skull. How does it know what is happening outside? The connect between the outside world to the inside human body is through the sensory system, and the exterior receptors gives this information about the environment to the brain. In this, we can further classify it into 2. One is the near receptor and the far. What is it that is near? Like say tactile is the touch, gustatory is the taste. If you see both, immediately, if you place your hand on a table, that is hard. The message goes. You are able to appreciate that it is hard. Gustatory is, if you place the food on the taste bud, you are able to identify what taste it is. So immediate, near ones. Those are the receptors which are there, and it gives information about the near. Next is the far, vision. We are able to give information about what we see near, what we see far away also. Again, the smell. Yes, definitely. As we walk into our house, we don't actually see to smell. We are able to see, oh, something yummy is being cooked at home. So it is far. This receptors are able to get the information even from a distance. The same way auditory, which is near and far. So these are the receptors which gives information about the far and the near, but mainly far is the vision, the olfactory, and the auditory, which is the hearing. Next is the interoceptors. Actually, in the sensory systems, we always leave these interoceptors, but we don't do much work, but it is nice to know what these interoceptors do. These are the receptors which are present in the organs which is inside the body, like the stomach, then, all the organs. Why it is very necessary? It is very necessary for the efficient functioning of the organs and the coordinated function of the organs. And it is also through the interior receptors, we also get to understand the abstract concepts of hunger, thirst, and other things. So interior receptors or interior receptors are very, very important, and they are found in our viscera or organs and give information about the organ functioning to the brain, and the brain responds in such a way that they are able to function effectively and in a coordinated manner. Next, the most important thing we as therapists should understand is the proprioceptors. Proprioceptors gives information about our own body. Very, very important. Proprioception, and it has two. These receptors are two. One is the proprioception, one is the vestibular. Where are the proprioceptors are there? It's in the muscles and the joint, and the vestibular give more about information about the gravity and the movement, and proprioception is more about the movement, because the receptors are present in the muscles and the joint, and vestibular system, it is in the media, it is present in the medulla, and more to do with the gravity, movement, and body balance. So this is how the sensory systems work to integrate the information and take it to the brain. So we have seen the sensory systems. We have seen the what is the basic principle of the sensory integration. Now, how does it develop, and when does it develop? So actually, if you see, it starts developing in the fetal life itself. The baby, the fetus, experiences a lot of stimulus when it is in the womb itself. That is why we say pregnant women should sit and rock, because it's a vestibular senses which develops first and the baby is able to recognize. So constantly in the fetus, the child is bombarded with sensory stimulus, and that is how the child also develops in the womb. The first system to mature is the vestibular system. And so it is very, very important. Cradling, rocking, we say all these things to be done in the first year of life, because it is able to understand and appreciate and connect it, because it is the same thing which it has experienced when the child has been in the womb. Next is the tactile and the proprioceptive stimuli develop. How, after the baby is born, as the child grows, it has to explore, it has to move. That is when the tactile system develops, and then followed by the proprioceptive system. Please recall what these systems help us also, because it will help us to understand this. And as the child grows and explores the environment, the proprioceptive and the tactile system develops, and parallelly, the vision and the auditory, the visual system and the auditory system also parallelly starts developing as the child grows in age. All the senses develop and work together when, as the child starts playing with himself and the child starts playing with others. So what happens? Even as a child is developing, the vestibular, tactile, and proprioceptive stimuli forms the foundation on which the visual and the auditory systems integrate their input, and thereby the child develops in his motor level area, in his cognitive area, in his speech and language area, or in his social development area, or in his functional development area, and starts becoming functionally independent. And that is how the development takes place. So now because we said the vestibular system, the proprioceptive system, and the tactile forms the foundation on which other systems are built and developed, we just see what is it that the vestibular system helps us in. The vestibular system helps in emotional security by overcoming the gravitational insecurity. Because see how the movements affect other areas of development. Because of this insecurity which has been overcome, a lot of emotional security the child gets. Equilibrium and protective reactions are from the vestibular system. That is, by breaking a fall, body balance, able to balance and move forward, all these things are from the vestibular system. assuming anti-gravity postures which where the muscles work against the gravity, and transitioning from lying to sitting, sitting to standing, and then walking. All these and performing complex gross skills, that is after beyond walking. All these things are assisted by the vestibular system. Vestibular system also gives you a stable visual field, because your visual field has to be aligned with the body movements. Otherwise, what you are seeing and where your body will be moving are two different things, and that causes a lot of confusion and disorientation, where development is not accelerated, but development comes to a halt. Spatial orientation, that is how much of body bound, what is my boundary, where am I in this space, and how am I in this place. All the awareness of this also comes from the vestibular system. And the last but not the least is the bilateral motor coordination, which is very, very important, because bilateral motor coordination is not only with the upper extremities, is not only with the lower extremities, it is to do with the whole body, and that is very, very important for fine tuning and refining of movements, and that also the vestibular system contributes. Next is the tactile system. Primitive reflexes are all because of the tactile system. But we should note one thing: primitive reflexes, which has to be extinct. But in some children, you find that the primitive reflexes still get extended into adulthood. Then the area we need to work on is, we have to see whether the tactile system maturity is not adequate, or whether the tactile system input is too low, or the tactile system is overacting. So we need to work on that. Thereby we can reduce this. Bonding and attachment is also through the tactile system. A lot of attachment and a lot of emotion. Like, that's why we say when a child is born, to be hugged and then to be wrapped, all these things, so that they feel a sense of security, and that also gives them an awareness of through the whole body, what is my boundary. That is what we call as the body scheme. Otherwise, these are all things which we take it very lightly, but very, very important in the aspect of development, because I need to know where, through the entire wrapping and through the hug, through the whole body, because the skin is present everywhere. Tactile is through the skin. So it is very important that, a lot of security and the body scheme is developed through the tactile system. Next is the oromotor and the hand skills. Very, very important. What do you mean by oromotor? The oral and the motor skills. See, even our mouth is made up of a lot of muscles, and the oromotor skills to develop and the hand skills to develop, tactile system is very important. So what is the importance of oromotor system? Is it helps the child to transit in eating and feeding. A lot of children, a lot of adults don't like some food at all. They can't bite and chew food and eat. Thereby, the muscles don't develop adequately. In children with needs, it causes a lot of difficulty in production of sounds, thereby causing a lot of difficulty in speech. See how the one thing leads to another, and it really causes a development delay. And when they are not able to speak, there is a social development delay, and other things follows a pattern. So oral motor, that is movement of the oral muscles, is also one of the important factors which the tactile system contributes to, because it causes a lot of, it affects the feeding pattern of a child. It affects the, biting, chewing, sensor exploration of different textures of food and different tastes through the mouth. And it also helps, helps in developing the muscles which help in speech, and it also helps in an awareness to the brain that how the oral muscles needs to function. Then the hand skills, very important. A lot of our hand skills are only through our touch, exploring different textures, exploring different shapes, exploring different size. That is how our hand skills develop to form different grasp, different hold. We are able to touch food and eat. I will tell you one thing here: a child who has not explored and touched food and eaten will later have difficulties in writing, because it is the same fingers, it's the same hand, it's the same grip, it's the same hold which is used for both. unless and until the child has had a lot of exploration through hand in the early stages of life, you will see these children will have difficulty in their writing skills. A lot of parents we see feed their children, not allowing the hands to develop, but later on they will come and say the child is not writing. So but actually if you just change this, you see that the child is able to slowly start using his hand skills for both the activities. Then the protective function is also an important function of the tactile system, because we appreciate pain, we are able to appreciate heat, we are able to appreciate the different senses which causes to a certain extent harm or danger is also through the skin or the tactile system. Next is the proprioceptive. Very, very important, because it is there in the muscles and joints. It only gives us the sense of alignment of trunk, head, and other body parts. Otherwise, we should know, even when we close our eyes, if even if you are asked to draw a picture of somebody, you know where to put the head, where to put the body, where to put, say, after the head, you have the neck, then you have the long, trunk, and then you put the hands on either side, and then you put the legs, then you put the ears, eyes, exactly where it has to be. Children having that is because this sense of alignment comes from the proprioceptive system only. Children have problems in this, especially children with autism, LD and all. They have very great difficulty when you ask them to draw where comes what, because this system is either underdeveloped or it is, not matured enough to get this process going. Next, precision and ease of movement in body parts. Very important. If I need to move forward, it should be with ease, and it should be, precise. Even picking up objects, even sit to stand, everything. It is very, very important that ease of movement makes our life very comfortable to do our day-to-day activities, and that is very important. We use movement for everything. So this is also because of a proprioceptive system. Then another important thing, which is very subtle, is it maintains a steady arousal level, we say. So what does this arousal level mean? Now we are all in a webinar. Okay, we need to be at a certain state of mind to receive what is being spoken here. If it's a Saturday afternoon and then I had a good lunch, and generally we are feeling a little dull and lethargic, we don't actually, not there fully to receive what is happening here. The same way, the brain has to be always at a steady arousal level to receive the information which is taken from the which is taken from the environment through the sensory system, so that it is able to process and produce a learning or a response. That maintenance of a steady arousal level is done by the proprioceptive system. But I would say the arousal level always fluctuates for all of us. Like, we are not always at the optimum arousal level. Sometimes we are down. Sometimes when we are tired, our arousal level is low, right? And when we have exhausted ourselves, our arousal. But for a learning and for development and for anything to perform our task to the fullest possible ability, we have to have an optimum arousal level, at least through a certain period of time through the day. So that is also another important thing with the proprioception system helps. So before going to the method of intervention, so we just saw what are the sensory systems and how does it contribute, and what are the senses and how the information goes through. Then what is it? So what actually we do in the sensory integration therapy? We actually do something called a sensory profile. That is the sensory assessment. Basically, we do it for each system to say whether where is the child, whether the lag is in the proprioceptive or in the vestibular or in the tactile, or it could be in 2 okay and 2 less. And then where is it in the visual, whether it is overstimulated, understimulated, and where it is in the auditory. And because of this, what are the challenges the child is facing? So this is the baseline, which is called as the sensory profile, from which we start the sensory integration therapy. One thing I would like all of you all to remember is, when we do a sensory integration therapy, that one assessment is not enough, because sometimes it is a continuum, and it is based on, it is also to do with the environment we have been here, because the environment provides the sensory stimulation or the sensory input, or the input to the senses, or the information to the senses, if you can take it. So sometimes there will be a little bit of up and down, but if you see the challenges which the child is facing, like bilateral coordination not present, midline crossing is not present, then you know exactly which sensory system through activities we have to work through, so that those are being addressed and the child's ability to focus and attend improves, and thereby the child's learning and development moves forward. So sensory profiling is a very, very important tool which we do to assess the level of the child's sensory performance, and then keeping that as the baseline and the difficulties the child is facing, we chalk out a sensory integration program. So what happens in a sensory integration program? We basically have activities for tactile, proprioceptive, and the vestibular, because this forms the building base. And it is in a constructed setting or a room where it can be, the sensory input can be moderated, unlike in a normal environment. At home, you can't moderate all the input. Sometimes the input or the stimulus will be not what the child needs. So it will cause more harm to the child than helping the child to develop. So in a sensory integrative therapy room, we are able to control and moderate. It will have all the five senses stimulating equipments, activities in that same room. And based on the assessment, we need to facilitate the child to do the activities and see how the child is able to progress. So it is a specialized therapeutic setting, and it should be always child directed. It should not be you say do this, you do this. Okay, because the sensory need is from within myself. It's not the same for all of us. Okay, like how hunger, yes, all of us are hungry, but how much we eat when we are hungry is dependent upon the individual. All of us don't eat that same amount. The same way, the sensory input also is based on the child's direction of how much it needs and how the senses get satisfied. Based on that, we should take it, and we are not supposed to direct the child. Only when the child is getting stuck with doing the activities of the same senses, then we facilitate the child or guide the child to explore the other senses too. Next, always when you give a sensory integration therapy, you should emphasize on getting a very good response or a learning which should come through, and that should be the goal in your mind. And you have to provide the right challenge. It should not be too complicated. If you give too complicated a challenge, the information will not even go to the brain. It will get stopped there. The child will not cooperate with you. And so whatever you're trying to do will not go in the right direction. Then constant adjustment or activity depending upon the child's response. This is what I said. It is not the same activity every day. You have to keep, it is a continuum and it is dynamic, because it is we are constantly bombarded with sensory input from the environment thereby. So the assessment also will fluctuate. So you have to have a baseline assessment and see what the needs are of the child during every session, and then keep adjusting the activity depending on the child's response. Yes, it is a little challenging, but once you get the hang of how to go about it, it's really interesting to see when the child really responds and develops and is able to have move ahead in this development. So what is the sensory diet? It is nothing like a home program. So what is a diet? Diet is something which we follow to keep ourselves healthy. So to keep the sensory systems healthy, we give a sensory diet, because the sensory integration program maximum happens one-on-one. It has to be one-on-one. You can't have a group therapy in sensory integration. And it is only for 45 minutes to an hour. You can't have more than that. The rest 23 hours the child spends at home, where there is no control of the sensory information which he or she is receiving. So what you do is you give a diet to address the needs of the sensory system. So it is nothing but a planned, scheduled activity where the sensory integration therapist develops to meet the needs of the child's own nervous system. Everybody's nervous system is so individual and unique. You have to understand the child, and you don't give it on the day one. You only give it after 3 weeks of sensory integration program, because it is by then certain amount of integration would have happened, and then you start giving the home program on the sensory diet. What does it do? Why do you give it? Basically, whatever you have done in the department, you have to carry it over. Like we say, right? You do certain stretches at home, you do these exercises at home. The same way, this helps, you have to carry over whatever the sensory integration therapy we have given, and it also multiplies the effectiveness of the sensory integration therapy. So what happens is, whatever you have addressed it, it helps to maintain it, so that when the child comes for the next session, you can start from there and help the child to move. It also helps the child when you give a sensory diet. At home also, the child is calm, organizes, and it's alert. Thereby, it tries to explore the environment in a more meaningful way. So you are actually opening up the channel of development. Then what should you have in that? It should have activities for tactile, it should have activities for vestibular, and mainly it should have activities of proprioceptive. I really emphasize on this because this is the basic foundation on which the entire chain of development is built on. So what all you do, you can have skill-wise, grasp, fine skills, motor planning, coordination, need, and some tactile brushing, basically looking into the need of the child. So this completes completely the entire sensory integration. How do we go about it? The sensory integration therapy, along with the neurodevelopmental therapy, if both are combined, certain activities in the sensory room with a little bit of stimulation in the principles of neurodevelopment therapy, definitely multiplies the effect, and it enhances development very well. So having seen this, what are the stages in the special needs we can see? Where all we can contribute as therapists, or where all our therapy is very effective. Whether it is a child with autism, or whether it is a child with ADHD, or whether it is a child with other developmental needs, whatever the stage may be. Early stage is, we say, 0 to 7 years. Middle school stage is 7 to 14 years. Pre-vocational stage is 14, sorry, it's written 4, it is 14 to 16 years, and vocational stage is 16 years and above. Just a small this thing about early stage. Early intervention, the most important stage in the development of a child, because that is when the sensory system starts developing. Sensory system starts developing from the time of conception, and starts developing, consolidates, matures by the time the child is 8 years old, and it is refined all through our life. Because of that only, all of us learn things in a different way. Because of our senses only, we all address issues in different way. Because of our senses only, we all are really learn different art programs and excel in something, and because of that only we are able to address our emotionality, and approach and address and understand a situation very differently and solve it in our own way. Then in the early intervention program, it is identification, which is very important. In today, identification is even pushed for all these cognitive challenges even before 1 year. A lot of research in this area is being conducted, and it would be really nice if we are able to identify these things also through other, like, their motor skills, their fine motor skills, their midline coordination, then the bilateral coordination. With all these finer aspects, if you are able to identify them still early, not at the school going age, I'm sure they can all be corrected even before they get into the school. And this is one thing which has been really successful in the early intervention program, where I have put together and worked with children. Then motor development lays the foundation for other areas of development. So we really need to work on the motor development area and work through movements so that we are able to get to the other areas. Then sensory exploration through various senses in the childhood really is the food for the brain to develop, understand both cognitively and through the senses. then early intervention given timely helps them to mainstream in life. We generally say early intervention is only 0 to 3 or 4, but I really have worked and found that 0 to 7 is an ideal age, because because of our culture, our factor, and our understanding, lot of early childhood difficulties are only identified in school, but they don't need to be pushed into a special school. If you don't understand, all these children like ADHD and LD, all of them will be landing in a special school, which we don't need. But if you are able, so they need an individual, highly intense early intervention program where can they be included back into the mainstream school itself. So thereby I always work 0 to 7 in the intense early intervention program, addressing it through the sensory needs and the sensory integration therapy. Next is the mid-school. Okay, child has come to the early intervention program, mild and moderate children with difficulties. We have been able to integrate them into the normal environment. What happens to children who have not been able to integrate into the normal environment, who are severely affected? Yeah, they do require a special school, and that is when we call this as a mid-school program. How do we as therapists contribute here? This is a stage where a lot of academic learning in typical children happens. So in children with special needs, even though normal academics don't follow, there are a lot of areas where we work on the functional academics which is required to function independently in future. That is what is defined as functional academics, and that is what will be the main goal in the middle school program for children with needs who need the special school program. So what can we do there? A lot of work with movements to facilitate concepts of function like problem solving, association, transitioning. All this can be done with movements and then generalized to academic learning, so that it develops as functional academics is the main key thing in the mid-school program. Because even as I told you, movements lay the foundation for academic learning and other developments. So through movements, you can help them how to do the problem solving. Through movements, you can help them to work on association. Through movements, you can teach what is transitioning. And then these concepts can be transfer of learning into a functional academic learning. A lot of work is required at this stage on coordination and hand manipulation activities, because very, very important to address behavior issues. Hand manipulation in activities, in case they have to read, they have to write, they have to do their functional skills, you need hands for everything. Hand manipulation is not only the fine hands and fingers, it is also to do with the proximal control of the joints, it is also to do with the crossing, and it is also to do with weight bearing of the hands, it is also to do with the coordination, it is also to do with hand to hand coordination, hand to leg coordination, and it is also to do with eye hand coordination. So many things we need to work there so that we can help the child to develop in the mid school stages. Next, very, very important area which I've already touched is the ADL training. It has to definitely start here, because this is the stage when we are working with movements and we are working on the areas of functional academics and the hand skills. So the ADL skills also needs to be trained. As I told you already, anything we do involves motor, involves cognition, and involves sensory. So you can use the sensory integration modality, you can use the movement therapy, you can use the sensory systems and enhance the cognition, and you can get them to be independent in their functional skills like brushing, toileting, dressing, grooming, because you really contributed to the growth of this child or the individual. The next is the vocational program. What does this vocational program grow? Now from the school stage, we have come to the adolescence or the adult stage, where the child or the individual young adult needs to start to look into being trained for an independent life. So what do you do here? Endurance and physical fitness, because a lot of these children have other issues along with this, like seizures, metabolic disorders, so many other things. They are on medications and other things which really causes them to be sedentary. They don't move around much, so their physical fitness and endurance really takes a backseat. So you really need to help them because keeping their physical fitness and endurance helps them psychologically and helps them to make feel nice about it. Next, again, the same hyper extremity and hand functions. Here, the goal being a little different, because we have come to the stage of vocational program where academic learning is not going to be feasible. So we are going to train them in some skill which requires hand, again, vocational skills, whether it is paper bag making, or whether it is plate making, or whether it is going to be in the computer, or whatever you can name it. You need the skill of the upper extremities. So you have to train the some places you need to even train the muscle strength, if based on the skill which they are going to be trained. So the upper extremity control and hand functions are the main areas which we need to look at this in the young adult stage. Independence in ADL skills becomes much more important here, because we have seen young adults as old as 16 above, 20, 24, who are not able to use the toilet, who are not able to dress themselves, and it is a big agony for the parents, and it is really, really hard at that stage to train also. So if you actually see from the early intervention to the mid school to the vocational training, that independence in ADL skills is something which we have to push it right from the beginning and see that they get the independence within the mid school or the vocational program. Otherwise, it is already a difficult journey for the parents, and it becomes all the more difficult and socially unacceptable. So a lot of parents don't even come out with their young adults, and they all become secluded, and leads to more emotional problems and emotional trauma for the parents. And the young adult has not become independent. The main so importance to independence and ADL skills is really, really important, and we have to focus that. And whatever needs to be done to achieve this, as therapists, we really, really need to help the child, or the mid-school child, or the adult, or the parents, and work closely with them, because ADL skills can not be achieved because there is a sensory issue. ADL skills cannot be achieved because there is a motor issue. ADL skills will not be achieved because there is some issue in the cognition. So we need to understand that and give appropriately the therapy and help the child and the young adult and the parent to develop in this area. One important area of ADL skill not being achieved, when they have tactile defensiveness, they have inability to touch the food. So you will see even a 24-year-old being fed by the mother. When they have the oromotor problems, they will not be able to take food which has to be chewed. They will only take food which they can swallow. So how do you overcome all this by therapy? How do you give the tactile program? How do you give we have something called brushing protocol. We have something called weight bearing protocol. We have something called hand sensitivity protocol. Applying all these things and parallelly working with the child on, helping the mother and the child to touch the food and eat, you'll be able to balance it and somewhere lead the child to become independent in his functional skills. So having spoken of all this, finally, where do you think we are? What is the significance of therapy in this area? Definitely, I feel, developing a child totally is very, very important. And that really helps to facilitate including many children in the mainstream life. Including many children in the mainstream life is, otherwise they will be in the spectrum of disability. Rather, they all mild, moderate children who are in that spectrum should be addressed appropriately and correctly. And the role of therapy is very significant by helping them to be included into the mainstream society. And because of this development which is happening, you are able to prevent future academic delay also of the child. You are able to accelerate development, and you are also able to help some children in overcoming development. Not all children get included. As I told you, some children, a lot of them get into the vocational category where we are not able to address their issues, and because sometimes the severity is high. By doing all this, you are able to improve the quality of the life as they move into the adulthood. make them independent, and also help them to earn a living. And this lessens the burden of the parents of these young adults and gives them a lot of peace and emotional security, which is very, very important. I'm telling you, in this journey, I met so many parents. It is more than the child or more than the adult with special needs. The trauma which the parent undergo is just, it's not describable. It is very, very hard to see them. So you are able to give a good quality of life to both the child with special needs and to the parents. By doing all this, what happens? That's the next. Today, sometimes in school, the child is not able to write. So they send them for an assessment. Next is, we have to fight for this child to be back in the school. We're telling them that we will do what is necessary, but the child should not come out because he or she will overcome this and get into this. But no, today, schools and other places are not willing to accept if the child is having a mild deficiency or whatever. So the way we push many of them into the disability spectrum, even though they need not go into it. So that should also be minimized. So to summarize what I have spoken, and my wish is that we have, a lot of uh, uh, awareness and interaction of these subjects in the undergraduate courses, and we are able to have students interning in this field and bring best practices of interventions, assessments, and programs, and creating an awareness to students and our community, so that more people get into the field and help these children to develop. My future wish will also be to say that if we are able to have a developmental screening, like as we do our vaccination at a policy level, it would be really great, so that the amount of individuals developing into disability can be minimized by early identification and early intervention. So thank you, everyone. Thank you once again, all of you all. With this, I conclude my session and I'm open for questions. Thank you.
Thanks a lot, ma'am. Thanks a lot for sharing the nitty-gritties of the developmental therapy. It was a very mind-blowing session. And there is one question in the inbox by Sujita, which states that, like, can you suggest an effective therapy as a calming strategy for autistic meltdown?
Okay. She wants an effective therapy for
calming strategy.
For calming. And sensory integration therapy really helps in a meltdown. The thing is, you should avoid a lot of auditory input, and visual input should be taken away. A quiet corner will really help. Something like a beanbag, which gives you a whole body, sensory stimulation, and leave the child in such a way that he or she is not going to harm herself and others. And after 5 to 7 minutes, you give a little bit of joint compression, starting from the proximal joint to the distal joint, and follow this for the day the child had a meltdown, at least thrice, and for 3 days, and then you stop it. So that by doing this over a period of time, sensory integration therapy, we do it in blocks for 3 weeks, and then give it some period of time, so that we are able to see whether the senses are able to take the stimulus naturally and integrate themselves. And then we start the next block. So at the time of calming down, auditory input less, visual input minimize, a quiet corner with a lot of tactile feedback. After 5 to 7 minutes, a lot of proprioceptive input without talking, as in the form of joint compression, and sometimes a little bit of a wrapping and rolling also would help. But the entire thing should be a little bit of handled without a lot of instructions, auditory input, move people away, and then try to understand to a certain extent some amount of what could be the cause. And maybe when the child come out of that, you can try to have some sort of an alternative communication also, so that he or she is able to express what was it that we somehow need to find out the cause for the meltdown also, because there will be a pattern. Maybe you can use an alternative communication also to see if the child is able to communicate and see what he or she was the cause of the distress. It could be a simple overstimulation of the sensory systems also. There could be something which was there, which was overstimulating him. And if you take that out also, the child will respond. But you don't know. So initially, lessen the auditory input, visual input, calming room, little more of tactile, and the proprioceptive is the way to go for meltdown.
There's one more question from Nigamaja Hariharan, madam.
Their
How would,
students, their
no,
staff.
the alumni.
Okay.
Yeah. How would you help kids with feeding difficulties to eat a variety of food?
Yeah, very nice question. So, first of all, at the age of 6 to 7 months or 8 months itself, the child generally starts picking the food and putting it in the mouth. That they should allow. The parent should allow a child with feeling difficulty, even if they are going to mess it up, it's fine. So the awareness to touch and explore food through hands should be the first thing which should come. Then I would suggest, apply the different taste in their hands and allow them to, whenever the hands go to their mouth, they will do some amount of licking. So it's okay. So it's, licking enhances the taste buds and they are exposed to different taste. Another way of doing this is apply different tastes, one taste a day. Suppose today it's going to be generally for children with autism and development disease, we say don't give too much of white sugar. So you can use honey or something like that. Apply honey over the lips. So each time the tongue touches the lips, the taste of honey gets in. Tomorrow it should be salt. Day after it should be sour. Day after it should be something else. So this gives a oral re-education to the brain, and slowly the child starts accepting different varieties of foods. Because when you want the child to eat different varieties of food, you should include taste, texture, both, because it is very important, because both the combination only the child will want to explore. So you have to give exploration in the taste this way, applying it to the hands, touching and feeling in the hands, applying it on the lips so that the tongue touches the lips, and it should be done 5 times in a day, the same taste. Next day something else, next day something else, and the last concluded with heat and cold, because food is given hot or cold. So concluded with that. Do this for 3 weeks and then present the food in semi-solid, not mashed, that half cooked, then fully cooked, and then introduce the variety. Slowly you will see that the child starts, taking, it will not be a breakthrough in one day, but you may have to repeat this 21 days, give a gap of 2 weeks, introduce food, 21 days, give a gap of 2 weeks, introduce food, but you will reach somewhere within 3 months. The earlier you do, the better it is. But please, for children with feeding difficulties, oral exploration, hand exploration is beautiful. But if they are on the feeding bottle, please stop that, because that will definitely prevent the higher facilitation to get into the way. So if you are in the feeding bottle, you have to stop that and give a lot of biting and chewing food, like the puri urundai, the kadalai urundai, all that, where the mouth opens and they are able to bite and eat. Some sort of, because that they generally like the taste, and it's also oral movement and exercise, and little bit on blowing and sucking. These things together, we can definitely address the feeding of this child.
There's one more question from Jayalakshmi. Have you tried painting or drawing to calm them for older kids?
Yes, definitely, but not at the time of the incident. You understand? Because what happens when there is a meltdown, immediately you bring a painting, even the painting has been, shoved away or, kicked off or whatever it is. So we have to be calm when there is a meltdown. As the proprioception, I said, you can end the session after the proprioception, or if the child is not allowing for proprioception techniques, then slowly you can bring in even the painting or the drawing, and that will also help to the child to express himself or herself. Why this agony? Why this meltdown? As I said, you can use any alternative communication also to do it. So just give some time before you bring the painting. That is my experience, and that is the protocol we follow. And in case you want the meltdown to be, extinct, you need to understand when it comes, how it comes. It's like an analysis, and work on the painting as a therapy for a couple of weeks. That also helps, because painting also gives a lot of sensory feedback. You can do even wet on wet, rather instead of a brush, you can use directly hand also and help the child to paint, because it gives a lot more of sensory input, and that also calms down. Yeah.
Yeah. And there's one more question from Mrs. Rajeshwari.
Yes.
What would be the strategy that you would adopt to correct the tiptoe gait in ASDs, autism spectrum disorders?
Right. A lot of weight bearing has to be done for the tiptoe correction, and multi-sensory weight bearing. That is multi-sensory in the way is using of hard textures, using of soft textures, using of something like a texture like a sand, and providing feedback mechanism with weight bearing, and traveling to the calf and the knee for a period of time will definitely help. That is one thing which you and a little bit of whatever shoes they are wearing, right? You give them a little, that sort of a feedback from the feet, so that it gives a constant sensory stimulation, which will help them to overcome this. In sensory room, we use even water beds for tiptoes. Water beds, so that it gives that bouncy effect. And when they are able to do certain single leg standing, alternate leg standing, then squat to stand, it gives an effect. So you can't give it like squat to stand, you can't do it, but you have to make it fun in such a way you are using the movements along with the different textures and the weight bearing and the feedback through the feet, through the gastrocs and the knee. And definitely a little bit of sensory feedback mechanism on the shoe also will help, or the footwear that the child is wearing. And then get him to walk barefoot to see how much of correction has happened. And please tell the child, don't walk on tiptoes. That is something you should avoid, because the child is not even aware that he's walking on tiptoes. And if you are trying to correct that by verbal thing, it doesn't make any sense.
Okay.
Yes, Aman. Anything
Yeah,
else?
there is one more question from Nigamija Hariharan, madam.
Yes.
Can you suggest a few proprioceptive activities that the parent can easily do?
Yeah. So, can she be a little specific? Because proprioceptive activities cannot be very generalized. Is it any specific for the age group? If she can specify, I would definitely share. Otherwise, I'll tell you to give her, because it's not one size fits all.
For child around 5 years, ma'am. For child around 5 years.
Child around 5 years. Okay. Carrying weight on both hands and walking a small distance. That could be one. Having weight in a backpack, and negotiating steps or obstacles, with a weight on the bag, like a school bag, where you can put a lot more of weight on that, and you can help it to do. And generally giving them a little bit of proximal joint compression, which you can teach the parent, because it is very easy. It's not very difficult. And functional positions like, crawling and just moving forward on the hands, and then moving backward on the legs, moving forward on the leg and moving backward on the legs. And in crawl position, weight bearing on one hand and both legs and reaching on the other, so that the proprioception also shifts between both this thing. And half kneeling, pushing the wall. Half kneeling, if you just say push the wall, the child will feel, it seems like a senseless activity. So half kneeling with one hand against the wall, pushing, with the other hand transferring, so that you are able to bring in even the midline crossing and bilateral coordination. Alternated to that, and then front foot standing, the same thing can be done. Then some amount of weight at the shoulder during the squat to stand, and transferring objects. Few things which you can do very easily at home. Anything to do with both hands, carrying a bucket of water with both hands, and then lifting a little bit of 1 kg or 2 kgs of rice and moving from one point to another. These things the child definitely can. Even wet clothes. squeezing wet clothes, because simple things are easy. This the clothes which are like pant and all is difficult, but the more the child learns to do that, it also helps with proprioception. Yeah.